So hello everybody, welcome to this little run through of ECGs. It's going to be over two parts. So in part one we're just going to be looking at some of the basic principles behind ECGs and how to look at them, how to interpret them. And in the second part we're going to be working through some examples. So let's take a little look at the standard ECG. This is a normal ECG trace for lead 2 normally. Those are the key waves as demonstrated there and the key segments. So if you remember how the heart itself depolarizes, obviously starts with the SA node, the sinusoatrial node at the top of the atria. That depolarization of the atria is shown with the P wave before going into the QRS complexes, which is where the ventricles themselves depolarize. And then the T wave at the end there is the ventricles repolarizing. You can sometimes see little U waves after the T wave, which is slightly smaller than the T wave. That's believed to be the papillary muscles attached to the heart valves repolarizing. Otherwise, there are a few key intervals shown there on the diagram. The first one being the PR interval. That's from the start of the P wave to the beginning of the QRS complex. That normally should be between 0.12 and 0.2 seconds, but we'll go into those in a bit more detail when we look at how to analyse the ECG. The other key interval to be aware of is the QT interval. Again, that's from the start of the QRS complex to the end of the T wave. You need to make sure that's normal. If that's prolonged, that can be a risk factor for certain cardiac diseases, such as torsades. So moving on, it's important just to reinforce the statement that if you have depolarization headed towards one of the leads, so in the direction of one of the leads, that's going to give you an upward wave. If you have depolarization going away from where that lead is picking up, that's going to give you a downward wave. So while we're talking about the leads, let's look at how we place them. So you have 6 chest leads, as demonstrated by the picture on the right there, V1 to V6, sometimes called C1 to C6. The chest leads give you a direct trace, so the image shown in the ECG is directly taken from that lead. And then otherwise we have the limb leads, which is demonstrated with the picture on the left. Red on the right arm, yellow on the left arm, green on the left leg, and then the black or the neutral lead on the right leg. People often remember this sequence by using the acronym RIDE YOUR GREEN BIKE. So when you take your tracing, this is what you'll get a normal looking ECG here. As you've noticed, this is what we call a 12 lead ECG, 12 separate images generated from the 10 leads that you've placed on the patient. Each of those leads is obviously looking at a different aspect of the heart. So we talk about territories, anatomical territories that the heart is looking at. And this just helps us give an indication as to where the pathology is, if there is a pathology in one of the leads. So sort of V1 to V4 are typically our anterior leads. The septum of the heart, the ventricular septum, is around sort of V1 and V2, so you might sometimes see the term anterioseptal being used. The lateral leads are V5, V6, 1 and AVL, and then the inferior leads, which is largely looking at the right atrium and the right ventricle, are 2, 3 and AVF. And I think this is probably most commonly used when we're talking about acute coronary syndromes. So if you have pathology in a certain territory of the leads, we often talk about an inferior ST elevation MI, for example, or an anterior ST elevation MI. Moving on to how you go about analysing ECGs, it obviously looks a little bit confusing if you haven't seen too many ECGs before. There's just lots of wavy lines and it can be very, very difficult to tease out the detail. So obviously we need a structure. And the structure we like to talk about is rhythm axis morphology. Now, as you've noticed by the text there, it's always important not to forget the patient details and the date and the time. Is it the right patient? Is it the right time? That's not just for ECGs, that's for all investigations, chest x-rays, blood results, everything. And in terms of the timings, one large square or 5 small squares is equivalent to 0.2 seconds. And a small square, which is 1 millimetre, is equivalent to 0.04 seconds. And this becomes important when we talk about normal values. So the first part of rhythm axis morphology is rhythm. This is essentially looking at the ventricular and the atrial rhythm, the rate, and the PR interval and things like that. Essentially checking if the electrical rhythm of the heart is functioning appropriately. So looking at the ventricular and the atrial rhythm, we need to know whether they're regular or irregular. And if it's irregular, is it irregularly irregular? Or is it a predictable irregularity? The best way to work out the rhythm is to get a little bit of piece of paper, mark all the QRS complexes, which corresponds to the ventricles depolarizing, and move that bit of paper along just to see if all those little lines that you've drawn on that spare bit of paper line up with the QRS complexes. If it's regular, that will happen. If it's not, that obviously won't happen. And you can do the same for the P waves as well. You then want to check the rate if you have a regular rhythm. It's often a little bit easier. You can count the number of large squares between 2 of the R waves and divide that number into 300. Alternatively, if it's an irregular rhythm, or even if it's a regular rhythm, you can just count the number of R waves on the rhythm strip and times that number by 6. an entire rhythm strip being 10 seconds. The next bit after rate is to look at the PR interval. That's the bit I mentioned previously. Normal being 0.12 seconds to 0.2, or 3 small squares to 5 small squares. And this becomes important when we're looking at things like heart blocks. So we need to know, is it absent? Is it prolonged? Or is it gradually increasing? And we'll talk to that a little bit more in part 2 when we go through some examples. The P to QRS complex relationship is important as well. That's making sure that the atria are marrying up with what the ventricles are doing. So the relationship there, or the ratio there, should be 1:1. And finally, the QRS width itself is important. So it should be less than 3 small squares. If it's broad, again, that can signify several different things, but mainly that the depolarization isn't coming from the preferred conducting tissue, i.e. the bundle of His or the bundle of branches. It's probably coming from the ventricles themselves, and sometimes what we call a ventricular escape rhythm. Again, we'll go into that a bit more in part 2. So after we've looked at rhythm, we need to look at axis. Now, axis is essentially the direction the heart is depolarizing in. As you can hopefully appreciate, the heart depolarizes in a direction starting from 11 o'clock down to 5 o'clock. The SA node is in the right atria, so that's sort of the superior and right-sided aspect of the heart. And that's travelling down to the apex of the heart, which is in the inferior left aspect of the heart. So a normal axis can be anything between minus 30 degrees and plus 90 degrees, as shown in that picture there. And that just shows that the heart's depolarizing in an appropriate direction. So it's going from the sinoatria node through the atria, into the AV bundle, down through the bundle of His and the bundle of branches, and into the left ventricle initially, then the right ventricle. Now, if you have often a larger ventricle, or some sort of pathology related to the size or the depolarization of the heart, a bigger QRS is often generated from a bigger ventricle, and that can essentially affect the axis. So we can talk about left axis deviation and right axis deviation. The pictures there are quite helpful in just demonstrating that, where the bigger QRS sort of swings the axis in a certain direction. So a typical sort of rule of thumb is that an enlarged or a pathological right ventricle will often give a bigger QRS, causing a deviation to the right, and a large left ventricle will cause a bigger QRS complex, causing a deviation to the left. Calculating the axis can be a little bit difficult. What you're supposed to do, the official way to do it, is to plot the overall deflection in millimetres of lead 1 and AVF. But the alternative and much quicker way to work out the axis is to look at leads 1 and 2 and the overall deflections in that. Are the overall deflections leaving each other, or are they reaching for each other? So if we look at the pictures there, in the top picture, the overall deflection in lead 2 is negative. So you've got sort of 3 millimetres of upward and maybe 10 millimetres of downward. So the overall deflection is negative in 2. And then in 1, there's an overall positive deflection, maybe 3 or 4 millimetres. So because you've got a negative deflection in 2 and a positive deflection in 1, they're going away from each other. So they're leaving each other, which would make it a left axis deviation. And again, in the example at the bottom there, you have an overall negative deflection in 1 of maybe 15 millimetres, and an overall positive deflection of maybe 6 or 7 millimetres. So they're reaching for each other, giving a right axis deviation. The final part of analysis, after we've done rhythm and axis, is to look at the morphology. So all the normals are documented there. So essentially you can't have a P wave that's too high or a P wave that's too long. So if you have a high P wave, we talk about peaky P pulmonale, which suggests pathology in the right atria. And if it's too long, it often may be biphasic, so you get 2 little peaks, and that can be a sign of a left atrial hypertrophy. Q waves can be normal, as shown there, so they can be deep in AVR and lead 3, but if they're about 25% of the height of the preceding R wave, or larger than 2 millimetres, they're likely to be pathological, which often indicates either an old myocardial infarction or a degree of infarcted tissue, or acute ischemia. If we're looking at the R and the S waves, the height is important, so we don't want them to be too high. That can be a sign of hypertrophy if the waves are too large themselves. And there we're talking about R wave progression in the chest lead, so that's V1 to V5 or V6. And this is essentially the R wave getting larger than the S wave as you move across the chest leads. The transition point is talked about there. It's kind of academic whether you work it out or not. It doesn't really affect much in clinical practice. The ST segments are key, certainly if you've got somebody complaining of chest pain or you're worried about an acute coronary syndrome. Anything over a millimetre in elevation or in depression may be an indication of ischemia. And the T waves, again, we don't want them to be too high. You get high T waves in lots of conditions, but hyperkalemia is the first one that springs to mind. And the QT interval, as already mentioned, normal range there being 0.36 to 0.44 seconds. That shouldn't be too long, and it can be a sign of cardiac pathology. So we're just going to go through an example now and talk about how to present your findings if you're on placement or whatever. So we get a little vignette. It's always important to read a vignette and put any investigation into the context of the patient. So here the vignette is a 27-year-old male who's normally fit and well, who attends for a routine operation and has an ECG. So based on purely on that vignette, we're not expecting to find anything. We're not expecting there to be pathology. We just need to keep a broad mind just in case there's something unusual. So there's our ECG. Again, if we go through our rhythm axis and morphology, looking at the rhythm to start with, it looks like it's sinus rhythm in that there's P waves to every QRS complex. If you calculate the rate, so I think it's probably easier just to count the number of QRS complexes in the rhythm strip. That gives a rate of around 78 or so. Looking at the PR interval, that's normal, so that's in between 0.12 seconds and 0.2 seconds. There's a P wave to every QRS complex, giving a ratio of 1 to 1. And the QR width is narrow, so it's less than 0.12 seconds. The axis, looking at leads 1 and 2, so the overall deflection in 1 is positive, and the overall deflection in 2 is also positive, so they're not reaching for each other, and they're not leaving each other, so that's a normal axis. And then looking at the morphology of the waves themselves, the P waves look fine to me, they don't look too large or too long. I can't see any pathological Q waves. It looks like there's normal R wave progression across the chest leads, so just picking up on that point. Following the R waves across from V1 to V5, you see they get gradually larger than the S wave. There's no abnormal size to the R waves or the S waves, they're not particularly large. Looking at the ST segments, again they all appear to be along the isoelectric line with no elevation or depression. The T waves are of appropriate size, they're not too large or too peaked, being less than 10 millimeters in the chest leads. And again, calculating the QT interval from the start of the QRS to the end of the T wave, that looks normal to me, so that's within 0.36, 0.46 seconds. So that's just how I like to document my findings when you're thoroughly analysing an ECG. I think it's important when you're looking at ECGs just to make sure you have a decent system and just go through. The only way you're going to really learn the normal values is with boring repetition, unfortunately. So documenting like that just reinforces it in your mind. And again at the bottom, because we're training clinicians, it's important to always put a diagnosis or a preferred diagnosis. This is where you combine the abnormal findings that you've documented above, if any, combine that in the clinical context and combine that with the patient vignette that you've been given and give a preferred diagnosis. So in this case, there's a normal ECG. And that's essentially it for part 1. That's everything I kind of wanted to go through. Hopefully it was helpful. I think a few key summary take-home points. Just remember your basics. So remember that depolarization heading towards a lead will give an upward deflection. If you remember your core principles, you can try and work out things when you get stuck from basic principles. Remember rhythm, axis and morphology. And I think just be slow, be methodical. Don't try and jump ahead, otherwise you will miss things, unfortunately. So have a little look at part 2. We'll go through some worked examples there and hopefully just reinforce some of the learning points in a bit more detail.